Good morning, third year students. Today we'll talk about biomechanics of the cranio-mandibular complex and different mandibular movements. The objective of our lecture and the expected outcomes to know the different mandibular movements and rotational and translational types. We have to know the different border movements and functional motions for the mandible. We have to know the different determinants of occlusal morphology. Here, a picture to remind you with the joint capsule and what we have inside the complex of the joint. We have superior compartment, as you can see in the picture, and inferior compartment. Superior compartment extends anteriorly below the articular eminence. And the function of this compartment, or the use of this compartment, is to allow the disc to move forward to support the condyle in extreme movements. However, in the inferior compartment, which extend down the posterior aspect of the condyle, as you can see in the picture here, that will allow the condyle to rotate forward against the undersurface or the underside of the disc. Again, here in this picture, you can see the different parts of the joint. You can see the superior compartment, you can see the inferior compartment in red color, and you can see the articular tubercle, which is part of the temporal bone, which is bony structure. We have also the articular disc in blue color, light blue. We have the mandibular subtemporal bone. And you have the head of the condyle, or we call it condylar process of mandible. In the next coming slides, we will see what are the different mandibular movements we have. Types of mandibular movements. We have different types of mandibular movement. We have basic movements, which are opening and closing, forward movement, which we call it protrusion, backward movement, which we call retrusion, and we have also lateral movements to the right and left. We have in three-dimensional, we have rotational and translation, and all these mandibular movements are result of simultaneous movement of both right and left TMJs, or it is abbreviation for temporomandibular joints. The first three-dimensional movement for the mandible is rotational movement. What we mean by rotation? Rotation is the action of rotating on or around a center or axis. So it is a movement of rigid body in which all the parts are rotating around an axis of rotation or a fixed line. Or any line from any point, if we drop any line from any point of this object to the axis, it will be perpendicular on the axis of rotation. So we have a rotational movement in the mandible. So you have to imagine a center or a fixed line passing through the two joints, and the mandible is opening and closing around this fixed axis. This fixed axis, we call it a transverse horizontal axis or terminal hinge axis. And during this opening and closing, the teeth can be separated, and then upon closing, they will occlude again with no positional change of the condyle. So the condyle rotate in its place without any translation, without any bodily movement. So it is a pure rotation, no movement for the condyle only rotating around a transverse horizontal axis. We call this rotational movement around terminal hinge axis or around the transverse horizontal axis. In this slide, you can see the terminal hinge axis or the transverse horizontal axis, which an imaginary line or axis that is passing through the condyles, and the condyles are rotating around this axis, purely rotating without any translational movement. So they are moving or rotating around this hinge upon opening and closing, but without it changing their place. We talked in the previous slides about rotation, which is one of the three-dimensional movement of the mandible, and we said that it is purely rotation without any translation for the condyle. But where does it occur? In the superior or inferior compartment or cavities? It happens in the inferior cavity between the superior surface of the condyle and the inferior surface of the articular disc. In this slide, you can see the reference planes of rotation. So rotation can happen in around horizontal axis, as you can see in the first left slide. Around horizontal axis, it can happen around vertical axis, and we call this frontal view when you look from the front. And in the last slide, sagittal axis. So any rotation needs axis to rotate around. It can be horizontal axis, it can be vertical axis, it can be sagittal axis. Again, to summarize, rotational movement occurs in the inferior compartment. It is a pure rotation without it changing the position of the condyles. It happened upon opening and closing movements, and we call it hinge movement. It happened around the transverse horizontal axis or terminal hinge axis. Again, it is a pure rotation. Condyles in this rotation are in their most superior position in the articular eminence, and this pure rotation without any translation for the head of the condyle is rarely to happen during normal function. Usually in normal function, we have some translation, we have not only a pure rotation, we have translation movement. So pure rotation happened only rarely in normal function. The second three-dimensional movement is the translation, in which a bodily movement will happen for the head of the condyle. So the head of the condyle will move bodily from its superior position in the joint. And if you want the glossary prosthodontic terminology for this, it is the motion of a rigid body in which a straight line between any 2 points of the moving body is parallel to the initial position. So it is moving away from the original position, but it's still parallel to the original position if you draw a line between any 2 points in this body. And we call it gliding or sliding or translation, all the same. In translation, the movement happens in the superior cavity or superior compartment, in which the superior surface of the articular disc and the inferior surface of the articular fossa, they are contacting or sliding against each other in translation. Again, it is in the superior cavity. In this slide, we will see a new position for the mandible, which is the rest position, or we call it physiologic rest position. This is a postural position of the mandible. This position usually when we are in resting, in a comfortable resting, in upright position. Like for example, while you are sitting, resting, you are not doing any activity. So and all the associated muscles for the mandible in a state of minimal contraction, no action, no stretching, no opening, no closing. So this we call it physiologic rest position. Like, for example, when you are watching TV, you are not doing any activity with a little space between your upper and lower teeth without any contraction for your muscles. This is what we call it physiologic rest position. So all the muscles are in equilibrium. There is no contraction. Your head is in upright position. You are not doing any activity. We call this rest position or physiologic rest position. This slide is very important, especially when we come to bite registration. You have to be familiar. Now, the vertical dimension, when you are at rest, as we said in the previous slide, when you are sitting comfortable and your head is upright, the distance from, for example, from the bottom of the nose to the bottom of your chin, for example, here in this picture in A position, we call this vertical dimension at rest. So if we have this measurement, okay, we call it vertical dimension at rest, which is VDR on this slide, okay? When you close your teeth together, so you are in maximum interdigitation or intercuspal position, we call it, when your teeth are contacting each other to the maximum, like in slide B. Okay, so you have shorter vertical dimension compared to the one in A, because in A there is a space between your teeth. In B there is no space. Your teeth are completely intercuspating. Okay, there is no space. The difference of space between A, which is at rest, and B, which is at occlusion, we call it freeway space, which is FWS on this slide, which is range between 2 and 4 for different people and different populations. So again, we have two vertical dimensions on this slide. We have VDR, which is the vertical dimension at rest. In this case, we are resting, we are not doing any activity, and there is a minimal space between our teeth. For example, 69, the vertical dimension at rest in this slide in A. In B, when we are biting in our teeth, when we are in maximum intercuspation between our teeth, so we have eliminated this space that was in A. Now we have a different vertical dimension, which is VDO in this slide, vertical dimension at occlusion. The difference, which is 65 on this slide, the difference between 69 and 65, which is 4, we call this freeway space. So the vertical dimension at rest is higher than the vertical dimension at occlusion by the freeway space. So the freeway space is the difference. So if you add the freeway space to the vertical dimension at occlusion, you will have the vertical dimension at rest. These vertical dimensions are very important when we do the bite registration for the patient. Because we have to provide the patient with a freeway space. This space is very important for speech and for function. Now, there are different factors you have to remember that it will affect the postural position, or as we said, physiologic rest position, the body and head posture. And as you remember, we said if you want to consider the actual and the right rest position, your head should be upright, not tilted, not bent. The sleep also affects the postural position, so you shouldn't take it in sleep. Psychic factors influencing muscle tone, like sometimes it is more contracted when you have like stress or whatever. Age. With age, the tone of the muscle will be less. Pain and muscle spasm also affect the rest position. Systemic factors like Parkinson's disease and tetanus. So any factor or any disease will affect the muscles, and their tone definitely will affect our physiologic rest position. In this slide, we have very important terminologies you have to know and very important definitions. We have the centric relation. Centric relation is a maxillomandibular relationship in which the condyle will articulate with the thinnest avascular portion of the disc with or against the articular eminence in the anterior superior position. This position, you have to know, it is independent of tooth contact. It is bony position. It is irrelevant to the teeth contact. It is bony position. And in this position, the mandible is in the superior anterior position in the joint, and it is purely rotational movement. There is no transitional movement for the condyle in this position. So again, centric relation is a bony relation between the head of the condyle and the head of the condyle and the articular eminence when the thinnest avascular portion of their disc is between the head of the condyle and the articular. And now in this slide, why centric relation is important, why we talked about this relation. It is important because it is, as we said, bone-to-bone position. And it is different from the maximum intercuspation position, which is MIP, because the other one is tooth-to-tooth position. So we need, when we make our prosthesis, to have a very reliable, very repeatable position, which is the centric relation. So if you want a repeatable position that everyone anywhere in the world do this prosthesis for this patient to have the same result, so we have to have a fixed and very reliable position to depend on, to build our occlusion on. So it is the centric relation because it is repeatable, it is bone-to-bone position, so it is not changeable. And this is the logical position to fabricate our prosthesis according to it. So centric relation and maximum intercuspation position are only coincident, so they fit on each other only in 10% of population. However, in 90% of population, centric relation is different from maximum intercuspation position, where the teeth are in their maximum intercuspation. So we can't depend on the maximum intercuspation position because we don't have teeth in the edentulous patients, so we have to depend on something repeatable and doesn't depend on teeth, which is the centric relation. As we said, centric relation and intercuspal position, which is ICP or maximum intercuspation position, as we said in the previous slide, only occurs in 10%. However, in 90%, there is a slide between them. There is a difference. There is a distance between them. There is a slide in 90% of population, which ranges between 1.25 plus minus 1 millimeter, and it is in a superior anterior movement. So when you are in centric relation and the patient wants to close in the maximum intercuspal position, they will move their teeth in superior anterior movement, as you can see in the arrow in the first slide on the left. And this slide sometimes with lateral components, so sometimes with this anterior superior movement, sometimes it's like shift to the right or to the left. And only when the centric relation coincide and fit with the intercuspal position, we don't have this slide. So the teeth are in their maximum intercuspation when we have the centric relation where the condyle in the most superior anterior position in their in the joint. Okay, so in 90% of the population we have a slide between the centric relation, which is more posterior. We have to slide a little bit anterior and superior to reach our intercuspal position. In this slide, just I want you to know, this slide show the drawing of the superior border of an envelope. We will come later to it. This is only the superior border, which is the movement of upper and lower anterior teeth. I want you to notice only this sharp angle where the arrow is pointing. When it is sharp like this, when it is point, not a line, which it means that the centric relation and the intercuspal position are equal, are coincident. However, when there is a slide, this point will be a line. So we have centric relation, point, and then line connecting between the centric relation point and intercuspal position. And when it is just single point, it's sharp like this, it means that we have the centric relation overlapping or coincident with the intercuspal position, which happened only in 10% of population. As we said in previous slide, we have a superior contact border of movement, that it is a border you can draw reflecting the relation and the up and down movement between the upper and lower teeth. Between the upper and lower anterior teeth, we have horizontal overlap and we have vertical overlap. And when the mandible moves forward, the incisal edges of lower incisors and the lingual surface of the maxillary incisors will make inferior movements. So when you try to move your mandible forward, your lower teeth will move against the palatal surface of your upper incisors and will move forward, as you can see the arrow in the upper picture, in the top picture. And when we continue until we have the incisors edge to edge relationship, this will start a horizontal movement, forward movement. So if you can look at the superior border we have downward line, small one, and then a straight horizontal line, which represent first the downward movement of the lower incisors against the palatal surface of the upper incisors, and then when we reach edge to edge, the movement start to be horizontal. And when we draw these lines, it represents the superior, we call it superior contact border movements. In the next slides, we will talk about the different movements in different axes and different planes. In this slide, we will see the different types of border movements. First, what we mean by border movements? Border movements, it is the maximum movement. It is the outer most external border of the movement of the mandible, the maximum that it can reach to the right, the maximum it can reach to the left. And if we draw lines in different planes, this will give us the border movement of the mandible in this plane. So it is the maximum movement. The mandible will move through this outer range of motion. What is the limitation? Why there is a limit? Why there is a border? The mandible cannot go beyond this border. The limitation because of the ligaments, the muscles, the articular surfaces, and the teeth. So these are the limiting factors that will determine the outer range of movement and will determine the border movements of the mandible in different planes. Which planes we have? We have three planes. We have sagittal one, which is the green here. We have horizontal one or transverse one, which is the blue, and we have the coronal one, which is the red. And you have to be very familiar with these. We have to remember always these planes so you can understand, because we will have some movement when we look to the sagittal plane. So we look from the side to be able to see the sagittal plane. Okay? A transverse, you have to look from the top. Coronal, you have to look from the frontal to see the borders of the movement. So you have to remember the position of all these planes to be able to imagine the range or the border of the movement in each plane. As we said, what are the determinants of or the factors that will limit the movement of the mandible? These are the ligaments and the teeth, okay, to resist the effort of the muscles, okay, to prevent extreme movements beyond the ability of the ligaments and the teeth. This slide, remember to look at the green plane, which is the sagittal plane. So you are looking to the patient from the side of the face while the patient is opening and closing. So while the patient is opening and closing, if we draw this movement, we will get this picture with this numbering 1, 2, 3, 4. 1 is the posterior opening border. 2 is the anterior opening border. 3 is the superior contact border, how the upper and lower incisors relate to each other during this movement of opening and closing. And 4 is the functional range, where most of the time we are in our function, representing 4. So this figure or this picture represent, if we, for example, put pencil or light between the centrals, the lower centrals, okay, and start to move, opening and closing, it will give us this drawing. And this drawing, you can see it on the green plane only. If you look from the top or front, you can't see. You have to look from the side, lateral view, to be able to look to the green plane. So remember, you have to look to the green plane to be able to see this figure. This is very clear view that we are looking from the side. So this is the drawing for the sagittal plane. We start from RCP, which is the retruded contact position. Then we have a slide to the intercuspal position, because we said 90% of the people, they are not coincident, so you are sliding. So here there is a line. Remember, in one slide we draw it a sharp point in case we have it coincident to each other. So there is a slide to the intercuspal position. So the patient will slide his teeth anterior and superior to have intercuspal position. And then the teeth will move downward. If you remember, the lower anteriors will move downward against the palatal surface of the upper anteriors. Okay, and then we reach edge to edge. So we have E here, flat line, and then further movement to the protrusion. So the lower teeth are anterior to the upper teeth where the protrusion. And then we have the anterior border of opening until T. What is T? Let's go back to the RCP. RCP, we said it is the retruded contact position or centric position. R is rotation. So from RCP to R rotation, when we open the mandible, but the mandible is still in pure rotation without any translation, it doesn't leave its place, the condyle. And then after R, that's more opening beyond R will result in translation, which is T, which means the head of the condyle will start to move against the articular eminence. So from R to T, this is a translational movement that will happen in the superior compartment, as you remember. And from RCP to the R, we have the rotational, pure rotation that happen in the inferior compartment. Okay, so this is the border movement, the border movement of the mandible in sagittal plane. So we can't go, this is the maximum for this patient, for this person. It cannot go beyond this because it is limited with joints and with teeth. Okay, so this is what you will see if we put, as I told you, pointer between the lower central incisors, and the patient start to function from the very retruded centric relation or centric position to the intercuspal position, to the edge to edge, to protrusion, and then rotational opening, and then maximum translational opening. So you will end up with this envelope or this drawing. What are the determinants of movements again in sagittal plane? For example, the superior border, the determinants are the occlusal and incisal surfaces of the teeth because it is related to the sliding of lower incisors against upper incisors. So these are the determinant factors. Anterior and posterior borders upon opening and closing related or determined by ligaments of the joint, by the morphology of the TMJ, articular eminence, all these things. This is very important thing to remember. Functional movements usually are not border movements. Usually we are functioning inside the border movement. We don't go to the extreme, to the border movements. So functional movements are not border movements, okay? And they are determined with our neuromuscular system. So remember that functional movements are not border movements. As you remember in the previous 2 or 3 slides, we have number 4. So the functional movement was within the border movements, inside the border movements. So the functional movements usually doesn't extend to the border movements, okay? And it is under the control of a neuromuscular system. Just to remind you, the posterior opening border movements on the envelope, where is the face of a patient there, we have R and T letters. So the posterior opening border, it has 2 stages. The first stage, when the condyle is purely rotating only, we call it terminal hinge rotation or movement, and in this case only rotation, there is no movement to the condyle, and it is up to from 20 to 25 millimeter opening only beyond between the incisor edges. Beyond this, the mandible will start to translational movement, and in this case the condyle will move against the articular eminence. It is beyond the 25 millimeter. And this is T on the posterior opening border. Again, this is the second stage of opening, which is from R, point R, rotational, to point T, in which there is anterior and inferior translation to the condyles. And this maximum opening reaches up to 40 to 60 millimeter, not beyond that, because it is limited with the capsular ligaments. Now, when we reach to point T, which is the maximum opening, the inferior lateral pterygoids will start to contract to close the mandible. After it is maximally opening, the inferior lateral pterygoids will contract to close the jaw, and this will generate the anterior closing border. So it is the anterior closing border generated by the contraction of inferior lateral pterygoids. So we are going all the way back, but not in the same way on the posterior opening border. It is more protruded. The mandible is protruded. The mandible is anterior to the maxilla in this path back, okay? So it is not a pure hinge, because part of it is a translation, and the mandible will start to go back to its position, okay? And again, ligaments will start to produce posterior movement of the condyle. So there is a translation back, and then there is a pure rotation again to bring everything back to normal and to its position. So the anterior opening, or we call it the right way, actually it is anterior closing, because when we are opening to the maximum at T, then the inferior lateral pterygoids will start to contract and to close the mandible, okay? When we go back totally, if you can see in the picture, the lower teeth are forward to the in relation to the upper teeth, so they are protruding, and then all the ligaments will start to stretch the condyles back to its position. So this is the anterior opening border. This is only to summarize your information. The same point, the same explanation as before, so you can just revise everything, and you have to memorize these points by heart, because you may have such a sketch in your exam with different points, and you have to know which point is this and what does it mean. I have explained this slide before, but just I put it back to remind you how we draw in sagittal plane the superior border, just to remind you the relation between upper and lower anterior teeth, but already we have explained this slide and the next slide as well. This slide to show you the functional movement, and as we said, the functional movements are not border movements, and they are under the effect of a neuromuscular system. In this slide, it is like a tear in the middle, and you can see it starts directly from the intercuspal position. Why? Because most of the function begin typically from the intercuspal position. When the teeth are maximally contacting, we start our functions. So this is the logical position to start with, and then the function starts from there and below. So it is all around the intercuspal position and within the envelope of movement, but never to be a border movement. It is within the border movement. Again, as we said, the functional movement starts from the intercuspal position, dropping downward slightly a little bit forward to the desired position of opening, and then return a little bit in a straight pathway, slightly posterior to the opening movement and the way back. Again, it is within the border movement. The second border movement after sagittal border movement is horizontal border movement. In this slide, we will see how horizontal movement happens and how we can see it. We have R on the figure is the right side, L is the left side, and the patient is trying to move his mandible toward the left side. We call R orbiting or non-working. So the condyle, the one that the movement happened away from it, we call it orbiting or non-working. And the left in this slide, we call it, and the left condyle, we call it rotating or working condyle, which is the condyle towards which the movement will happen. Okay, so remember these terminologies. Now, on the right side, the right inferior lateral pterygoid will contract, and the right condyle will move anteriorly and medially and inferiorly to achieve the lateral movement. However, on the left side, the left lateral pterygoid is relaxing. The left condyle remains in the centric relation without any change. And this will result in left lateral border movement. So this will result in the movement of the mandible towards the left. Again, R is the non-working side or non-working condyle or the orbiting condyle. The L is the rotating or working condyle towards which the movement will happen. And the end result of this will be the movement toward the left. So here we have left lateral border movement. So here we will draw the lines if we have, which is the horizontal border movement. So we have the intercuspal position. We have, first the centric relation, which is the most posterior one, and then the patient can move to the intercuspal position. So there is a slide here. Now, from the centric relation, okay, the patient can move to the left as we have seen in the previous slide, okay, or to the right. The same thing, to left or to the right. So we end up with the black line and the red line. okay? And then from the maximum side, to the left, or to the maximum side right, the patient can move forward, where is the black line again, and forward the green line. So we are in a protruded position now. The end result will be this rhomboid shape, which represent the horizontal movement in all borders, maximum right and maximum left with opening. So this is the horizontal view. This is when you look from upward, and this, if you fit it on the top of the postal envelope, this will give you the sides of the envelope from the top. As we said, we will learn each one in 2 dimensions, and then if you put them all together, it will give you the envelope, the postal's envelope motion. In here, to make it more clear, we have learned the left lateral border, here the right lateral border, in which the left inferior lateral pterygoid will contract, then the left condyle will move anteriorly, medially, and inferiorly. However, on the right side, which is the working side in this case, because the movement is toward the right side, the pterygoid muscle will be relaxed, and the condyle on the right side will remain in the centric relation, and this will result in total in a right lateral border movement. So if we combine the right lateral with the left lateral border movements, we end up with the full shape of the border movements in horizontal plane. This is very important thing to understand. For example, if the patient wants to move toward the left side, okay, so we said the right side will be the orbiting or the non-working or balancing condyle. So all these terms are the same. If we are looking from the top, which is the blue plane, the horizontal plane in the top picture, okay? And we are imagining like the patient started to move laterally. Okay, the dotted line in the bottom picture is the sagittal plane. So if you imagine the angle that will be formed between the sagittal plane and the lateral movement, so the mandible is shifting toward the left side, so there will be an angle will be formed between the sagittal plane and the lateral mandibular movement. If you see this from the horizontal plane on the blue plane, this angle we call it Bennett angle. So Bennett angle is the angle formed between the sagittal plane, the lateral mandibular movement viewed from the horizontal plane. In this slide, we will talk about Bennett movement, and this is different from Bennett angle. So Bennett angle on the non-working side, on the orbiting side, on the balancing side. However, the Bennett movement happened on the working side, which is the bodily lateral movement of the working side condyle as the mandible makes the lateral movement. So this shift, and we call it side shift, in the working side condyle, we call it side shift or Bennett movement, and usually it is 0.75 to 2 millimeter. And again, the amount and direction and timing of this movement different from one patient to the another, according to the joint structure, to the ligaments, the border movement of this patient. So the bodily lateral movement of the working side condyle as the mandible making the lateral movement, again on the working side, we call it Bennett movement or side shift. However, the Bennett angle happened on the non-working side. Again, during the movement to the lateral side, as we said, the condyle, the non-working condyle or the balancing condyle will move medially, anteriorly and inferiorly, if you remember. This medial movement, it depends on where is the medial wall of the condyle. The more the medial wall of the condyle is medial, which means it is away from the condyle, that the lateral translational movement will be greater, so more distance. For example, 1 here in this slide is shorter, so the medial wall from 1 to 1. From 2 to 2, it is more distance. From 3 to 3, it is more and more distance. So it depends on the anatomy of the condyle, the place of the medial wall of the condyle. It depends. So the medial wall is from the condyle. So according to this distance, the mandibular lateral translation will be greater and greater according to the position of the medial from the condyle. Now we will talk about the last and the third border. We talked about horizontal and sagittal. Now we will talk about frontal or vertical border. Now the third border movement is in the frontal plane, and you can see it on the coronal plane, which is the red one in the top picture. If you can imagine, the patient is moving to the right, moving to the left, and doing the maximum opening from front, you will result with the drawing the bottom picture, and it is shield shaped. And let's see what these numbers represent. So if you imagine the patient in the intercuspal position, ICP, and then the patient moved to the left side. And remember, please, that the left side in the picture, it is not your left side, it is the left side of the patient. Okay, so it is opposite of your right and left. The one is the left lateral superior border, when the patient is closing his teeth to the maximum and moving his teeth against each other to the left side. And then from there, he or she tried to open wide. So this is the left lateral opening border, which is opening from the lateral. Okay. And then 3 is moving to the right lateral side, which is the right lateral superior border between the upper and lower incisors, and then opening from the right lateral, which is number 4. So this will create the shield shaped, which is the frontal plane movement. Frontal plane movement. PP is the postural position when we are at rest position. So to summarize, we have 3 borders of movement for the mandible. The top left one is the sagittal plane. So if you look on the sagittal plane, you can see this envelope or these borders during the different functions between upper and lower centrals. The middle one is when you look in the horizontal plane. And the last one is the frontal when you look at the coronal plane. So if you collect all these together, you will get the possible envelope of movement. So if you imagine the shape, you put from the sides the possible, the sagittal plane from the sides, and on the top you put the rhomboid shape on the top, and if from the back of the puzzle of the envelope you put the frontal one, you will have 3-dimensional shape composed of all these 3 drawings. Thank you for listening. You need to read it or to study this lecture many times. Listen to my notes carefully, because I have said every single important information. And then we have a revision and discussion session. You can ask whatever you have. If you didn't understand any question or any slide, we can go back and explain it. Thank you for listening.